Good morning. The Subcommittee on Indian and Insular Affairs will come to order. Without objection, the Chair is authorized to declare recess of the Subcommittee at any time. The Subcommittee is meeting today to hear testimony for an oversight hearing entitled Modernizing the Implementation of 638 Contracting at the Indian Health Service. Under Committee Rule 4F, any oral opening statements at hearings are limited to the Chairman and the ranking minority member. I therefore ask unanimous consent that all other members' opening statements be made part of the hearing record if they are submitted in accordance with Committee Rule 3.0. Without objection, so ordered. Ask unanimous consent that the gentleman from Montana, Mr. Downing, be allowed to sit and participate in today's hearing. Without objection, so ordered. I will now recognize myself for an opening statement. Good morning, and thank you to our witness and witnesses in the second panel for being here. Today we are holding an oversight hearing titled Modernizing the Implementation of 638 Contracting at the Indian Health Service. 50 years ago, Congress passed the Indian Self-Determination and Education Assistance Act. The law empowered tribes to take control of federal programs that directly affect their communities. In the health context, that means Title I contracts and Title V self-governance compacts, what we collectively refer to as 638 contracts and compacts. Today, tribes and tribal organizations manage the majority of the IHS budget through 638 contracts. This is a testament to the success of self-determination and self-governance. But it also means IHS's mission has fundamentally changed. Instead of serving primarily as a direct provider, IHS must now negotiate hundreds of complex agreements, process amendments, pay support costs, and support increasingly sophisticated tribal health systems. How IHS can meet that modern mission is the core oversight issue before us. We know there are serious challenges. Tribes regularly report delays and uncertainty in basic 638 administration, slow action on contract amendments, lack of clear process maps, and long waits on 105L leases. IHS does not publish standard metrics or review timelines or pending actions. Without consistency or information sharing, tribes cannot plan effectively, and delays ultimately affect health services on the ground. The Government Accountability Office, or GAO, has raised similar concerns. IHS has been on the GAO high-risk list since 2017 for deficiencies in capacity, oversight, and demonstrated progress. The most recent iteration of the list acknowledges some effort, but concludes the agency still fails to meet key criteria for removal. That finding aligns with what tribes often experience on the ground. Too many delays that turn self-governance into negotiation rather than a predictable process. Variation across the 12 IHS area offices remains one of the biggest challenges. Some areas maintain strong collaborative relationships with tribes. Others are known for slow responses and unclear guidance. Unlike the Bureau of Indian Affairs, which recently updated its self-governance manual and standardized its policies, IHS still lacks uniform guidance. That absence contributes to uneven performance and prevents tribes from receiving consistent federal partnership. Another major structural issue is electronic health record, or EHR, modernization. Tribes in IHS still rely on RPMS, a legacy system that is now more than 40 years old. IHS has selected a new EHR system and is working on deploying it, and we appreciate the administration's efforts in this area. Finally, we are meeting at a moment when IHS is proposing a major strategic realignment of its structure. The stated goal, creating a more accountable, efficient, and self-determination-driven agency, is one all of us share in principle. If done thoughtfully, this realignment could reduce variation across areas and strengthen technical support. Our responsibility today is straightforward: to assess whether IHS is equipped to support the self-governance system that Congress created and which tribes have embraced. That means clear guidance, transparent data, timely contract processing, consistent area office performance, and modern systems that work for tribal governments. But tribes have made clear that they need more detail, more transparency, and more assurance that promised reforms will translate into real improvements. Our responsibility is something that is critical, and I look forward to hearing from our witnesses on these important issues, and making sure that federal implementation is as strong as the self-determination principles that is meant to uphold. The chair now recognizes the ranking minority member for any statement.
Thank you, Chair, and good morning to everybody out there. Wonderful to see our tribal leaders and some of the experts and visionaries in the field of self-governance in the audience. I look forward to hearing your testimony. And Deputy Director Smith, it was marvelous seeing you at Santo Domingo last week, where we were able to celebrate what happens when a tribe takes over and operates its own systems, where you're able to bring together the mission, in that case, their early child care education mission that a tribe has, with its cultural values. So it is rooted in both providing the trust responsibility to the tribe, but rooted in the tribe's direction and self-determination and cultural preservation. It was wonderful to see you there. And I love being able to look out at the audience and see some of the people that we heard from at our hearing in Oklahoma City to evaluate the Indian Self-Determination and Education Assistance Act as we celebrate its 50th year. The witnesses at their hearing, including Principal Chief Hoskin and Mr. Spaan, illustrated how vital the Indian Self-Determination Act has been for Indian country. It's such a foundational law because it's rooted in not the idea, but the knowledge that tribes know their needs and how to address them best. You've been doing it since time immemorial, and the federal government needs to celebrate that, recognize that, and make it possible so that you can do it all the time in healthcare and in other areas. Because healthcare is indeed one of the best examples of how self-determination and self-governance can transform a community and save lives. And we saw in Oklahoma that you are saving lives not just of your own community members, but of those in the community around you. It benefits the tribe and the local communities. I am a bit concerned because the Trump administration has acted in ways that undermine healthcare services and self-determination. In March, President Trump rescinded Executive Order 141112 that directed agencies to increase accessibility and flexibility of federal funding, promote compacting, contracting, co-management, and co-stewardship with tribes to administer federal programs and services. Recent reporting showed that IHS's workforce had a 30% vacancy rate. The administration's attacks on federal workers hinders its ability to provide health care for Native Americans because you can't provide the services, all of those increased compacting and contracting that the chair mentioned requires people to process those compacts. And these issues have become even more pressing after the IHS announced in June that they are proposing a significant realignment of the agency. Now listen, everybody in this room knows that we need to do better. The IHS can do better. Deputy Director, I appreciate you smiling and nodding at that because we all agree we must make improvements. And I think they need to be significant improvements. But I would suggest that we need to make sure that those are done in better alignment for Native Americans. First, IHS must hold future consultations in geographical diverse locations so all tribes can participate. You must give tribes detailed information on the alignment before each consultation so that it's productive. We have heard that the past consultations were not as productive as they could have been because the tribes didn't have advanced knowledge to be able to respond to what the proposals are. And you know me, I'm a huge supporter of self-governance. I worked and negotiated self-governance contracts and compacting. But we need to remember that not all tribes are in a position to enter into compacts or contracts. So we do need to ensure that providing health services as is required needs to continue for those tribes who choose not to compact or contract. We need to make sure that there is adequate staffing at the regional and area office, and that the staff at the local office who best understands the needs and practices of a particular tribe are equipped to negotiate and partner with them. Centralizing power and decision-making in D.C. could potentially slow down responses to tribes and make things more inefficient. But if we get things right, there's great promise for improving health care in Indian country. As you know, I'm working on legislation to expand the Self-Determination Act to other HHS programs that tribes utilize. It would enable tribes to blend together behavioral health funding from SAMHSA, public health funding from CDC, and IHS money to provide more comprehensive care. It would cut bureaucracy and give tribes more of a say in running their own healthcare systems. I hope this legislation can be considered and that we work on it on a bipartisan basis. I truly appreciate the bipartisan support for tribal self-determination and self-governance, and appreciate that it is one of our major priorities in this committee. I look forward to hearing directly from the tribes doing this incredible work. And, Mr. Chairman, I yield it back.
Thank you very much, Ranking Member Ledger-Fernandez. The Chair now recognizes the Ranking Member of the House Natural Resources Committee, the gentleman from California, Mr. Huffman, for any statement. Mr. Huffman.
Thank you, Mr. Chairman. I have a unanimous consent request before we begin. I'd like to enter into the record a recent report from the Energy and Climate Intelligence Unit. It is entitled 10 Years Post-Paris, a Decade That Defied Predictions, and it is about the amazing progress, 90% of new electricity capacity being wind and solar globally, renewables overtaking coal, and saving around $467 billion in fossil fuel costs. This is part of the benefits of a clean energy future, a climate reality the committee should note in the record.
Without objection.
Thank you, Mr. Chairman, and welcome, folks. I appreciate everyone who's traveled here and look forward to the testimony. This is an important hearing, and of course, we know that 50 years ago, Congress passed the Indian Self-Determination and Education Assistance Act, ISDEA. This is a cornerstone of federal Indian law, and it has provided tribes with flexibility to develop and administer programs that address unique needs of their communities while strengthening tribal self-determination. It's been utilized across law enforcement, natural resources, education, and health care, which, of course, is the focus of today's hearing. The Indian Health Service is the primary agency providing health care in Indian country, and this law has allowed important partnerships with tribal governments and urban Indian organizations through self-determination and self-government compacts to better administer services. In fact, I'm impressed that tribes now administer over 60% of IHS budget through these Title I contracts and Title V contracts. And this shows that they have the ability to effectively manage programs and meet community needs. And while 638 agreements have provided greater autonomy, obviously, there are persistent challenges that remain with ISDEA implementation and IHS operations. So, Mr. Chairman, thank you for choosing to hold a hearing on this subject. We know that staff recruitment and retention have long been issues at IHS. These are familiar issues, certainly, to everyone on this subcommittee. But under the Trump administration, we have seen it get a lot worse, frankly. Many more challenges, widespread chaos at the agency and the administration as they've worked to dismantle the federal workforce. We know earlier this year they tried to lay off 2,200 so-called probationary employees, right? But this included doctors, nurses, and other critical care staff, and when they quickly realized this was a terrible idea, they backtracked, exempting those folks while attempting to move forward with laying off about 950 other employees, and literally within a few hours, they realized that too was a terrible idea, and ultimately rescinded the layoffs, but the damage was done. Because of this chaos, since the administration took office, we've seen over 1,000 employees leave IHS through early retirement or voluntary termination. Combined with longstanding chronic understaffing that predated all of this chaos, we now have a 30% vacancy rate and historically low acceptance rates. So you put those together, and that's just a serious problem that we have to acknowledge, part of the context, essential context for this whole conversation. Now, I know the department is deploying public health service officers into the IHS system to fill gaps. That's fine, but it's certainly not a permanent solution for the many problems we're seeing. Increasing vacancy rates and declining acceptance offers combined with pre-existing chronic understaffing means that we're at serious risk when it comes to tribal health care and health disparities, which we know already existed for American Indians and Alaska Natives. So I'm glad we're talking about pursuing modernization efforts. We all support improving health care delivery in Indian country. But for modernization to succeed, we have to be driven by tribal leaders and healthcare professionals who work in the system every day. And we're hearing concerns that some of the consultation that's been conducted so far on modernization is inadequate, with some regions lacking meaningful in-person options. So I hope we can work on that. And I also hope that we can include funding. We have to include funding if we're going to get this right. But it's an important conversation, Mr. Chairman, and I look forward to hearing more from the witnesses and yield back.
Thank you very much, Ranking Member Huffman. Now I'm going to introduce the witness for our first panel, Mr. Benjamin Smith, Deputy Director, Indian Health Service, U.S. Department of Health and Human Services here in Washington, D.C. Mr. Smith, you and I spoke before, and I know you've mentioned you've done this before testifying, but I just wanted to remind you that under committee rules, you are to limit your opening statement to 5 minutes, but your entire statement will appear in the hearing record. To begin your testimony, just press that talk button on the microphone. We do use timing lights. Green means go, yellow means you have got 1 minute left, and red means please wrap up any answer as quickly as possible. I will also allow you to testify before the members begin their questioning, and that will be the same for the second panel as well. And so, Mr. Smith, I now recognize you for 5 minutes.